The objective of this presentation is to establish the basis of the diagnosis of myelomeningocele. The information in relation to the prognosis and evolution of children affected of myelomeningocele should be discussed with the parents, and the different options regarding the evolution of the pregnancy. Probably, if someone asks us which of these two fetuses have the intracranial images seen above, taking into account the morphological structure seen, we will answer correctly if we chose the fetus B. We all know that the images we are seeing corresponds to the lemon sign, which represents the frontal depression, and the banana sign, described at the end of the 80s, which gave us a turnaround to the diagnosis of this pathology. In the time where the ultrasound images was with less definition and less resolution, the images of the intracranial anomalies could make us suspect of this pathology. In that way, the screening of the myelomeningocele changed. However, every time we see the sign and other intracranial signs, we should assess the vertebral column, and we will only diagnose the myelomeningocele once we have seen the lesion directly. We should never make a diagnosis based in ultrasound markers. The myelomeningocele is one of the neural tube defects and is one of the central nervous system most frequent anomalies. Within them, spina bifida represents 50% of neural tube defects, and from this, 85% are open spina bifida or myelomeningocele. Its incidence is estimated in 1 of every 3,000 newborns. Thanks to the markers which have displaced the detection throughout alpha-fetoprotein in maternal serum, the prenatal detection rate is high. It is important to have into account that the lesions produced as consequences of myelomeningocele are permanent injuries and always will be severe neurological sequelae, and these injuries will determine the physical appearance and the social integration of these children into the society. We should take into account that the myelomeningocele impact is not only in a personal way, but also in a familiar and social way. Let's base this lesson in a clinical case, in a second trimester ultrasound at 19 weeks of pregnancy, in which the intracranial assessment we evidenced the morphology of the cranial depression, lemon signs, the form of the lateral ventricles, these central structures in the midline of the interhemispheric line, and in the cerebral section. We see an obliteration of the cisterna magna, and the banana sign, which talks about the morphology of the cerebellum. These are the cranial markers of myelomeningocele. These cranial markers, lemon and banana sign, especially banana sign, Arnold-Chiari type 2, which corresponds to the herniation of the cerebellum into the foramen magnum, and is the responsible of this morphology. Also we see a reduced cephalic perimeter, and the depression of the frontal bones. These are the cranial markers of myelomeningocele. Nevertheless, there are other cranial markers, the supratentorial markers, which can make us suspect the presence of myelomeningocele, which are associated to Arnold-Chiari type 2 malformation. These are the presence of elongated thalami, sharpening of the lateral ventricles, and the reduced distance from it to the occipital bone, interhemispheric cyst with trapezoid form, quadrigeminal cyst, and in the sagittal sections the herniation of the cerebellum in the foramen magnum. This will condition that the development is not completely normal due to the pressure and traction, additionally to the loss of cerebral spinal fluid. This pressure and traction that generates the herniation of the cerebellum will condition the alterations of the midline structures. It is frequent to find anomalies in the corpus callosum of these fetuses and an alteration of the midline structures, besides the obstruction of the cerebral spinal fluid. With the latest images techniques, we could prove that this association of the midline's defect with the myelomeningocele and Arnold-Chiari is present between 30 to 50% of cases. With these techniques of MRI diffusion images, we can see how is the corpus callosum image at the comparison with the hypoplastic corpus callosum, especially of the posterior part, or the presence of hypogenic corpus callosum. This is an interesting review published in Nature Reviews in 2015. This is the same case of the intracranial images seen before, in which we can identify the lack of skin in a portion of the vertebral column. This is a defect in which we can see the myelomeningocele cell, and inside we can distinguish the nervous fibers, and we could establish that it affects 5 vertebrae. In the coronal planes, we can see how there is a spindle form with separation of the lateral processes, and its interior we can see the medulla and the cystic appearance, in which the arachnoids and the spinal medulla is prolapsed. We also can assess how the vertebrae are well disposed, so we can rule out the presence of hemivertebrae, and if we count them, it affects more or less 5 vertebrae. We should assess as well the defect in axial planes, evaluating all the column, and we can see how the lateral processes are opened, and descending we see the defect. This membrane with cystic appearance with the medulla in its interior, and this white line that corresponds to the arachnoids, and this U morphology of the vertebral canal. This will make us think that we are facing a spina bifida with myelomeningocele. To locate exactly the point in which the defect starts, in which the lateral processes are opened, we could do it with the 2D ultrasound, but it's more graphic to see it with the 3D ultrasound. And here we can see how there is a lack of parallelism of the lateral processes, and the spindle form dissociation starts. The last vertebra with ribs corresponds to the last thoracic vertebra, and the next will be the first lumbar vertebra. So we see how the spindle form dissociation starts at L2 and ends at S2, so affects the 5 vertebrae we talked before, and alteration of the lumbosacral vertebrae. We can also see it with the MRI, in which the cerebellum is herniated into the foramen magnum, and the location of the lack of fusion of the lateral processes. Both techniques can ensure us the diagnosis. Every time we have a myelomeningocele, we have to assess the disposition and mobility of the inferior extremities. In the same case we've been talking about, we see how the disposition and mobility of the extremities is correct. The feet are well positioned in relation to the legs, so it is important to assess the attitude and mobility. Here we see another case in which we see a hyperextended and fixed extremities with clubfoot. To end, with the exploration of this pathology, we should perform an echocardiography and neurosonography to rule out associated anomalies, because the prognosis that should be discussed with the parents will depend not only in the defect, but in the presence of associated anomalies, whether it is an isolated myelomeningocele or a myelomeningocele with other anomalies. We should also offer a genetic study in which most of times we ask for array directly. First we perform QF-PCR and then array, but this will depend on the center. Finally, we should assess the fetal growth. In the first appointment, we shall try to determine the prognosis lesion, talk to the parents of the possible neurological impairment of their child, and to talk about the functional prognosis, which is different from the lesion extension, grade of hydrocephaly in the moment of diagnosis, mobility or paralysis of inferior extremities. We have to remark that the superior level of the lesion is the most important prognosis factor related with the functional level of the lesion. With this information, we have to tell the parents and counsel them and explain the prognosis and the possible lesions that this child will have regarding spina bifida. We should tell the parents that it is an anomaly with surgical treatment, and in an urgent way in a case of other options were not considered. In most of cases, we will need a multidisciplinary team due to the multiple circumstances this child may have. We should tell them also that the mortality rate is around 15%, related with the spina bifida lesions and complications as consequence of it or as consequence of the surgical procedure. The majority of them, 95%, is tributary of surgery, and in all cases will have some grade of hydrocephaly, sensitive or motor function, intellectual developments, sphincter continence, sexual or other anomalies. We have to take into account that around 90 to 95% of cases after surgery will need the collocation of a shunt. These rates are related to the location of the defect, but will be 100% in cases it is thoracic, 90% if it is lumbar, and some sacral defects won't have Arnold-Chiari malformation because won't have herniation of the cerebellum in the foramen magnum, and therefore the placement of a shunt won't be necessary. We also have to note that these cases that need the placement of shunt can have complications as the obstruction of it or infections. As the child grows, it will start to have motor complications. As we mentioned, the higher the lesion is, the more motor complications these children will have. In this scheme published in ultrasound, we can see how around 95% of the children with defect located above L2 won't be able to walk and will need a wheelchair. If the lesion is located between L3 and L5, although it's difficult to predict, around 50% will need wheelchair to move. And if the lesion is below S1, 95% of them will have a normal walk-in, but maybe will need to be held by crutches. But in the majority of cases will have some problems of walking. We have to explain to the parents that this motor alteration can be obvious at the first year of life, and which will always need some kind of support for sitting. Regarding the intellectual development, we can say that around 75% will have a normal development. However, it will be related with the grade of hydrocephaly or the alterations of the midline and the other associated malformations of the intracranial structures. For example, if there is a corpus callosum agenesis, it can have some grade of impact in the intellectual development, which can get worse while the child is growing and need more fine functions of the corpus callosum. Regarding the sphincter dysfunction, it can have retention or incontinence, but we can teach them some techniques as self-bladder catheterization. However, an important quantity of them will maybe need diapers. We also have to tell the parents that this child maybe will have some alterations that are impossible to predict in the prenatal life, which are sexual dysfunction, upper limb mobility alteration, oral motor alterations, scoliosis, and frequently psychological, learning, and social adaptation problems, and also the consequences of infections due to the shunt and catheterization. We can tell them they have three options. Termination of pregnancy. In Spain, currently 95% of parents decide the interruption. The postnatal surgery. The pregnancy follow-up will be done and are candidates at 24 to 48 hours after birth. And fetal therapy is one of the options that have been proposed in the last years. Regarding postnatal surgery, it is considered that an elective C-section must be performed to perform an early repair, which will prevent the infection of the neural tissue. However, we have to insist that the surgical repair won't recover the sensitive or motor alterations, that the morbidity is related with the superior level of the lesion, and that it should be managed by a multidisciplinary team. And while the child is still in the hospital, an early physiotherapy should be indicated. In Spain, 95% of the population perform a termination of pregnancy. It can be carried out at any gestational age at the moment of diagnosis. It should be confirmed by an autopsy to determine if there were associated anomalies or to perform a post-mortem MRI. We should tell the parents that spina bifida or myelomeningocele is one of the anomalies that is suitable for prevention. The prevention is done with folic acid, and the dose should be multiplied by 10 if they have history of neural tube defect compared with the normal dose. They should take from 2 months prior to the pregnancy 4 grams each day of folic acid. It is also important that there are cases described in which there is resistance to folic acid. In these cases, there are studies in which show that the combination of folic acid with inositol helps reduce the resistance. The latest research is done in Great Britain, Ponty study, and also tell the parents that an early guided ultrasound must be made to rule out the defect in the first weeks of gestation. Fetal surgery, which was the third option given, is something that has been attempted since 1993. The justification is the gradual lesion that could produce the friction with the placenta, uterine wall, or fetal movements, and also the acid changes that could cause the amniotic fluid in the nervous fibers. Posteriorly, after the correction, the capacity that has the nervous system to regenerate. With the aim to know the results of the fetal therapy, 3 different hospitals proposed a randomized study to determine the benefits of the prenatal surgery compared with the postnatal surgery. The inclusion criteria were the one you can see on the slide. The most important was to confirm the cerebellum herniation, confirmation of Arnold-Chiari, and that the location of the myelomeningocele was between T1 and S1. As we mentioned before, the level inferior to S1 don't have such a poor outcome as the others, and therefore the fetal therapy is not indicated. They also considered that the ideal gestational age was between 19 and 25.6 weeks, in which the injury of the nervous fibers due to the amniotic fluid wasn't totally established. And obviously, an isolated defect with any other structural anomaly and with a normal karyotype. They also established some exclusion criteria, which basically were the situation which could worsen the prognosis or maternal or fetal complications. The results were planned to achieve 100 cases in each branch, and the variables were distributed into 2 groups. The assessment in the first 12 months after birth, which included the death of the child or the necessity of placing a shunt, and the second group with evaluation after 30 months, in which the assessment of the motor function and mental development was done. The coordinators of the study decided to end it before achieving the 100 cases in each branch, because the results were significantly more positives in the group of fetal surgery. Regarding the variables evaluated in the first months, they saw that only in 40% of fetal surgery cases needed shunt in comparison with 83% in postnatal surgery. The same with the cerebellum herniation. 36% of the children that underwent fetal surgery didn't have cerebellum herniation in comparison with 4% of postnatal surgery. Other way to see this result is that only in 6% of fetal surgery cases had a severe cerebellum herniation in comparison with 22 cases of postnatal surgery. Regarding the variables assessed at 30 months, they saw that the results were superior in fetal surgery in walking without orthopedia at 30 months, but these differences were not significant and weren't either the mental development and motor development. We have to take into account, in the moment we explain to the parents the different options, the maternal complications are higher in the group of fetal surgery. The gestational age before 34 weeks of pregnancy is much higher in the group of fetal surgery. And the same with abruption placenta, the neonatal complications related with prematurity and the newborn weight, as well as sepsis, periventricular leukomalacia, and the maternal transfusion. As conclusions of this study, they stated that had significant results related to improvement of fetal outcomes. However, it's not the panacea, and the risk-benefit of the intervention should always be assessed. We must take into account that although we explain with objectivity the results of the study, the mother will always underestimate the risk and will overestimate the benefits to the fetus. As a dynamic guideline, it is important to perform a preoperative evaluation. Locate if there is a zone without placenta through which the intervention will be done. We also should assess the aspects of the defects. The surgeon who will perform the repair will want to know the dimensions of the defect. To see if they could join together the edges of the defects, we must give them the dimensions in the anterior-posterior diameter and longitudinal diameter. In this video, we will see the fetal surgery, in which we can see the different aspects of the surgery, always with ultrasound guidance. We must make the repair, exposing the defect, but without taking out the fetus from the uterus. Then apply the fetal anesthesia, and posteriorly, prior to that, we perform the 2 sutures as guidance. In between, we should perform the uterus incision, trying not to make it bleed. Once the uterus is opened, the mechanical sutures are placed, which reduces the time of intervention and help that the edges don't bleed. And then the lesion is exposed. Then the neurosurgeons will repair the lesion. In case it is necessary, a patch will be placed that will substitute the skin of the fetus. Then the uterus is closed. The amniotic fluid is repaired. Warm, obviously. After the intervention, tocolytics are given to avoid uterine contractions. Periodic surveillance is done to monitor the intracranial structures and the appearance of complications in the uterine scar. In the fetus, we can see how the herniation of the cerebellum persists in this fetus, and there is also some grade of ventriculomegaly. At 6 weeks post-surgery, we can see a significant change. The vermis is practically intracranial. We are able to measure its height, and all the intracranial structures have recovered their original form. It is important to assess as well the evolution of the ventriculomegaly, which will give us information regarding the necessity of shunt. In this MRI, we can see as well the evolution of the Arnold chiari. We can see how at 6 weeks post-surgery is almost solved. And we will confirm as well that there is no image compatible with myelomeningocele, the vertebral column, and we can see how the patch keeps the structures inside, and we can confirm it also with the MRI. This will be a postnatal cicatrization at 7 weeks. The patch was completely integrated into the skin, and the dermic complication will be solved with time. Here we can see the progression of this case. Here we can see the mobility of the inferior extremities after being treated with a physiotherapist since she was born. Then the mobilization and the maintained seated at 10 months of life, and the mobility at 22 months of life. Endoscopic fetal surgery has been proposed and it's being made for a few years. We think that there are some technical issues that are still not solved. It is minimally invasive, and that will be probably an optimal alternative with less maternal morbidity. To end, we must say that the key point of myelomeningocele is its incidence, the prevention that must be done to all the population, and perform an ultrasound screening scan at 12 and at 20 weeks. Currently, fetal surgery is one of the options in which selecting well the candidates can improve the prognosis. Highlight that the grade of hydrocephaly is what will determine the necessity of shunt. The level lesion is considered the best functional prognosis, and that postnatal and prenatal surgery have options as well as the interruption of the pregnancy. And thank you.